Senate's joint chair of this
Bonjour.
Honorable Marc Garneau, the House of Commons joint chair. Today
Excusez-moi, Madame la Présidente, il n'y a pas de traduction actuellement.
Okay, so hopefully
J'entends pratiquement pas la traduction, là. Il n'y en avait pas du tout. Là, j'entends un petit peu plus, oui. D'autre part, j'aimerais ça qu'on ajuste le son en salle. Et puis, j'aimerais ça savoir si les tests de son ont été effectués de façon positive pour l'ensemble des témoins.
Yeah, we're not getting English translation at the moment.
To answer Terry's question, yes, the test has been done with all the witnesses.
Okay.
And they all passed. And we should be okay now. There's sometimes a delay when we have problems.
Okay, we have tested the sound quality for each of our witnesses, and I'm told that we're ready to begin. But I didn't hear the English translation of Monsieur Thériault, so I'm assuming that everything is okay. Okay, so we'll continue and let's see how this goes. So we're continuing our examination of the statutory review of the provisions of the Criminal Code relating to medical assistance in dying. So just to remind everyone to keep, and the witnesses to keep the microphones muted unless recognized by one of the joint chairs, and a reminder that all comments should be addressed through the joint chairs. When speaking, please speak slowly and clearly. An interpretation in this video conference will work like an in-person committee meeting. You have the choice at the bottom of your screen, either floor, English, or French. So this evening, we'd like to welcome our witnesses. Thank you very much for joining us, and your testimony will be very important to our study. We will have in the order as follows: Dr. Chantal Perreault by video conference, followed by Professor Peter Rayner, Professor of Neuroethics, Department of Psychiatry at the University of British Columbia, followed by Dr. Jennifer Gibson, Associate Professor, Director of Joint Center, University of Toronto. So again, thank you to our witnesses, and we will begin with opening remarks. Each of you will have 5 minutes, and I hope to give you sort of a 4-minute warning. So at 1 minute remaining, I'll say 1 minute. And so if you can keep your remarks to 5 minutes, that will be very helpful for us to keep our time. So let's begin with Dr. Chantal Perreault.
Thank you to the joint chairs and the committee members for the opportunity to speak with you today. I live in Midtown Toronto on what was the shore of the old Lake Iroquois. This is the traditional territory of the Mississaugas of the Credit, the Haudenosaunee, the Huron-Wendat, the Anishinaabeg, and the Chippewa, and it is still home to many diverse Indigenous peoples. I'm a community-based MAID assessor and provider since July 2016, chair of the board of MAID House, a director of Dying with Dignity Canada, co-chair of the Dying with Dignity Canada Clinicians Advisory Council, and a member of the CAMAP Complex Cases Working Group developing the new national MAID curriculum. However, I'm speaking today as an individual, not representing any of these organizations. I appreciate the work of the Canadian government in considering so thoroughly and carefully the issues related to and raised by MAID. I have learned from listening to the many hours of testimony presented to the various iterations of MAID-related committees over the years, and hearing all these different points of view and being challenged by others' opinions and beliefs has contributed to improving my MAID practice. I have something to say about all of the aspects of this committee's deliberations, but will limit my comments today to advance requests. While I would much prefer to provide MAID to a person who is conscious and capable of providing consent at the time they receive MAID, there are conditions and events which occur which lead to the loss of capacity or even loss of consciousness. A number one fear expressed by most people I know and virtually all the patients I assess for MAID is that they will lose the capacity to request or consent to MAID and thus have to die a natural death in circumstances they find abhorrent and intolerable. The addition of Audrey's amendment in Bill C-7 went some way to alleviate the fears of some, but it did not go far enough for most people. Most of my patients are not interested in staying alive till the very end of a natural death. They actively choose MAID. However, they also want to live as well as possible for as long as possible. And there is much uncertainty when it comes to dying and thus much anxiety. Many people fear losing their physical capacities and thus their autonomy, or developing dementia and losing their cognitive capacities, or losing the ability to direct their own care. I am frequently contacted by people who want to be assessed for MAID because they think that they can then have it at a later time of their choosing, or in the event they become incapable in the meantime. Some, like the 2 patients I assessed yesterday, are shattered on learning that this is not possible. They don't want to die now, even if they are eligible, and they certainly don't want to set a date for MAID, but they know what is likely coming their way within a few months or years. They know what they want to try to avoid, and being able to write an advance request for MAID would alleviate a tremendous amount of their current suffering and anxiety about end of life. To date, I have cared for people like this by starting an assessment, gathering the background clinical information I need to know, and then keeping in touch with them on a regular basis. The assessment is completed if and when they want MAID and are prepared to set a date, sometimes months in the future, sometimes years. This gives them comfort and me ongoing work, but it does not replace the benefit an advance directive or advance request would confer. My mother died in 2009. She had fallen, hit her head, and in part because she was taking anticoagulants for one of her medical conditions, she had a brain bleed. She had surgery, which was successful, but she did not wake up, and the scans and examinations did not suggest a positive outcome was likely. Because I had talked with my parents over many years about their end-of-life wishes, and because they had answered my many questions and completed and regularly updated forms I gave them to create their statements of end-of-life wishes, I knew what to do. It was difficult, but I was reassured by the certainty that I knew what my mother had wanted in the event something like this happened. She died, never regaining consciousness, but with her family around her for the last days of her life. I've just come back from visiting my 96-year-old French-born father who lives in Texas. He would much prefer to live in Canada, what he considers the most civilized country on the planet, but he and my mother waited too long to start the immigration process, so he had to content himself with lengthy visits while he was still able to travel. He is now frail and weak of body, but sound of mind. He still carries a torch for my mother, whose pictures surround him in his apartment. While he looks like he should be suffering, he really isn't. He would be content if he went to sleep and did not wake up, dying peacefully, but he has no interest in or desire to hasten death in his current condition. I have provided MAID for many patients who were not as physically debilitated as he is. Were he living in Canada, suffering intolerably and asking for MAID, he would be eligible. He would also want an advance request. All this to say that advance requests and advance directives are important and actionable. Speaking with the designated attorney or future substitute decision maker about one's wishes in the event of incapacity is important. Clearly outlining the care one would want to receive and the care one would not want to receive is crucial. This is the information that will guide those tasked with one's care. The more detailed this information is, the better, particularly when it comes to advance requests for MAID. Ideally, there would be a national database to store advance requests. The onus would be on healthcare providers to inquire about the existence of an advance request and then to access it. This would allow patients, no matter where they fall ill in Canada, to have their wishes available to those who need to know in order to provide care. It's a big responsibility to take on the role of attorney for personal care, or SDM. It requires a lot of time, thought, and education. I think most people have no idea how much is involved or how much will be asked of them. And it will be even more complicated and complex when it comes to advance directives or requests that include MAID. But I believe it can be done and done well with careful planning and guidance. I have seen well-drafted advance directives at work.
Thank you, Dr. Pearl. Will you kindly wrap up? It is a bit over time.
Over time and with experience, templates for MAID advance directives can be drafted, refined, and improved. I would be pleased to provide you with my thoughts on what should be included in an advance request for MAID, and I have provided some in the written piece I submitted. Thank you.
Thank you very much, Dr. Perreault. And next we'll have Professor Rayner for 5 minutes. Professor, go ahead.
Thank you very much for inviting me to speak before this committee. I'm professor of neuroethics at the University of British Columbia, and today I'm going to outline for you a problem and then share some solutions. So if advance requests for MAID become legal, one might think that all that is required is to properly fill out a form, and when the time comes, the MAID provider will take care of the rest. Unfortunately, that might not be what happens. Evidence from the Netherlands, where advance requests have been legal since 2002, reveals that physicians do not always comply with dementia patients' wishes. Indeed, very few advance requests have resulted in dementia patients receiving MAID. In order to anticipate what might happen in Canada if advance requests for MAID in dementia were legal, My colleagues Adrian Byram, Ellen Wiebe, Sabrina Tremblay Hewitt, and I asked 103 MAID providers working in all provinces whether they would provide MAID under the aegis of an advance request that listed the sorts of specific circumstances that have been discussed often in these proceedings. The vast majority agreed that they would provide MAID if the patient was able to provide full consent. But as we changed the description of the situation to include circumstances that would likely apply as dementia takes hold, nodding yes instead of providing consent, or unresponsive patients but agreement by the family, or reliance upon the written advance request without anyone else to agree that it's time. As we moved along that spectrum, the percentage of providers who would offer MAID to dementia patients decreased to the point where substantially less than half would agree. These data suggest that advanced requests for MAID in the case of dementia do not represent a slippery slope. Rather, their implementation represents an uphill battle. This is a pragmatic problem that threatens to undo all the hard work that many of you have put into establishing a route for advanced requests in the case of dementia. So the question arises, how can we design those requests so that MAID providers will follow the wishes of individuals? Fortunately, we asked these very same MAID providers to propose concrete policy suggestions that might alleviate the situation. Their recommendations were exceedingly thoughtful, and I want to take this opportunity to publicly thank them for their insights, which are distilled in our 2021 paper that has been made available to the committee. I'd like to end my testimony by highlighting 5 points that stand out as what I would consider minimal solutions to our common dilemma. 1, the advance request should include a list of specific circumstances for the provision of MAID, with extra emphasis on the term specific. Periodic reaffirmation of the advance request would be the second suggestion, because continuity of one's wishes seem to hold particular sway with MAID providers. Thirdly, enumeration of why each specific circumstance constitutes intolerable suffering for the requester. MAID providers were generally receptive to the idea that individuals could determine for themselves what constituted suffering, but regularly commented that explicit discussion of the issue in the advance request would reinforce the idea that they were doing the right thing at the right time. Fourth, discussion of the advance request with family and relevant designated decision makers. Surprises at the time of provision puts MAID providers in an extremely awkward situation. And then fifth, a question asking the requester to be explicit about what they would want to happen if at the time of provision, things don't go as expected. For example, if a family member or the patient themselves objects to the procedure. As you prepare your report, I urge you to consider implementing these recommendations. Our data suggests that in order to have advance requests do what they are intended to do, we need to carefully consider the reality that confronts the MAID providers. They already have the morally weighty job of providing MAID. And if this legislation becomes law, they will be asked to take on the additional challenge of providing MAID based on an advance request. The success of the entire program depends upon us designing the advance request so that everyone, patients, families, and MAID providers alike, obtain the results that we all want. Thank you for your attention.
Thank you very much, Professor. And lastly, we'll hear from Dr. Jennifer Gibson. You have the floor for 5 minutes.
Thank you so much. And thank you for the invitation to meet with you in this important study. I'm director of the University of Toronto Joint Centre for Bioethics and an associate professor in the Dalla Lana School of Public Health. However, this evening I'm speaking as an individual, drawing upon my disciplinary background in bioethics and health policy and my experience as co-chair of the Provincial Territorial Expert Advisory Group on what was then called physician-assisted dying in 2015, and chair of the Advanced Request Working Group of the Council of Canadian Academies Expert Panel on Medical Assistance in Dying in 2018-19. I've had the opportunity to listen to several testimonies by previous witnesses over the last week. In the next few minutes, I hope to build on this testimony and indeed of my colleagues on the panel today and offer the committee some points to consider in its deliberation about the potential role, application, and conditions of advance requests for MAID. A first point to consider is that while advance requests for MAID may be relevant to persons with dementia, they're not relevant only to such persons. Discussions of advance requests for MAID often focus on dementia as the root cause and reason for a person's advance request. It is important, however, to distinguish between the grievous and irremediable medical condition, which may lead someone to seek an advance request for MAID, and the clinical circumstances which may result in their loss of decision-making capacity. For some patients, dementia may be both the grievous and irremediable medical condition and the basis of their loss of capacity. However, this is not necessarily the case. For example, consider an advance request for MAID from a person who is in active treatment for cancer or heart disease with an uncertain prognosis and who is also at risk of a potentially life-limiting event such as a stroke. Or a person who has inherited the dominant gene for Huntington's disease or the gene for early Alzheimer's and will most certainly develop the disease in the future, but may be diagnosed with another grievous and irremediable condition in the meantime. Or a person who has been living with Parkinson's disease for several years, knows that the end stage of their disease might be accompanied by dementia, and wishes to plan for this possibility whilst they still have the capacity to do so. It is important that a study of advanced requests takes this broader range of circumstances into account.
Sorry to interrupt, Dr. Gibson. Would you kindly move your mic a little bit up and also slow down for our translators?
Sure.
Thank you very much.
Yeah, thank you. A second point to consider is that persons with dementia do and can be supported to live with dignity, and there's much work to be done to strengthen and create conditions for this. However, for some persons, regardless of these conditions, advanced dementia may nevertheless be experienced as a source of intolerable suffering. As you have heard from other witnesses, recent public opinion surveys in Canada show strong support for advance requests for MAID. Some witnesses have attributed this to a general fear of dementia and institutionalized care, to limited accessibility of palliative care services, or to embedded ageism and ableism within society. The worry is that advance requests for MAID may tend to exacerbate and reinforce systemic barriers and societal attitudes that render persons with dementia, particularly seniors, vulnerable as a group, and to displace needed efforts to provide dignity-enabling care of all persons living with dementia. However, a focus on vulnerable groups as such tends to include the experience of individuals in the unique circumstances of their lives, including the impact that illness may have on their personal identity, their fundamental values, and their ability to engage in the world and the projects that matter to them and with the people they care about. A study of advance requests must consider both the vulnerability of groups and of individuals without collapsing one into the other. A final point to consider is that, as several witnesses before me have underlined, advance requests for MAID are complex undertakings with known uncertainties. However, there may be ways, as Dr. Rayner has pointed out, to reduce the complexity and narrow the uncertainty gaps. Advance requests for MAID raise important challenges about, first, the clarity with which a person has described their circumstances under which their advance request should be enacted. Second, the concordance of a person's current situation with the circumstances outlined in that advanced request. And third, the extent to which the patient's wishes are known and understood by the care team, the substitute decision maker, and family members. No piece of legislation alone can do this. And indeed, our previous experience with MAID in Canada underlines that multiple actors have a role to play. So as the Special Joint Committee study proceeds, one offering that you might serve all of us with is not only to be able to provide recommendations regarding what legislation may look like, but a broad canvas of what you've heard through each of these meetings that may be able to foster directions for the fuller range of actors who may have a role to play in its implementation and continuing evolution. I look forward to exploring these points further with you and with my panel colleagues. Thank you.
Thank you very much, and thanks to all of our witnesses. We will now move into questions from our MPs, and we'll begin with Dr. Ellis, who will have the floor for 5 minutes. Dr. Ellis?
Well, thank you very much, Chair, and thank you to our witnesses for being here. Dr. Perot, through you, Chair, if I might start. You talked about frequent reassessments, or in Professor Rayner's words, periodic reaffirmations. Can you give us a sense of how often those would be better suited to be done?
I think Professor Rayner and I were talking about two different things. When I see patients who would like an advance request, but because they're not available, we can't have them, I will meet with them and then I'll touch base with them every few months just to confirm their interest in MAID and to update my assessment. But I think he was talking about reaffirming an advance request periodically every 3 to 5 years or something like that, which I certainly agree with.
So just to be clear, through you, Chair, Dr. Perot, you believe that if someone has a desire for MAID, that their desire should be revisited every 2 or 3 months?
No, not in general. This is for patients who are not ready to complete the assessment. So if someone has completed the assessment and they want MAID and they're prepared to set a date for MAID, then we do that. And that date can be days, weeks, or even months down the road. But if someone's not ready to have the assessment completed, then I do what I call a rolling assessment. It's done over time, and sometimes that is spread out over a couple of years even.
Okay, I understand very clearly, yeah. And through you, Chair, if I may, once again, Dr. Perot, so in the words of Professor Rayner, do you believe there should be reaffirmations as we go forward to say, hey, you know what, are you even if you say, yes, I want MAID, are you ready to continue with that? Is that an important part of this for you?
It's certainly an important part for advance directives or advance requests. And I think anybody who writes an advance directive, which one can do now, should be reaffirmed every, periodically 3 to 5 years or something like that, because then you see the consistency over time of somebody's wishes. And if you can look at someone's advance directives over a period of 5, 10, 15, 20 years, and you can see that their wishes are consistent over that time, as a clinician, I would feel much more comfortable providing MAID to somebody whose wishes I knew were consistent over their lifetime, as opposed to somebody whose wishes were suddenly changed with a more recent advance directive that had never previously mentioned something like MAID.
Understood. Thank you. And through you, Chair, once again, Dr. Perot, as we get closer to that time, say you've established a relationship with that patient and you realize they have a dementing illness, would it then be important to increase the frequency of those reassessments?
Yes, absolutely. And I mean, reassessments as a MAID provider for somebody who's actively seeking MAID, certainly. And as well as if somebody has an advance directive, then that should be affirmed periodically in the course of their early dementia. At some point, they'll lose the capacity to understand what the advance directive is. And at that point, it should be stopped.
And through you, Chair, once more, Dr. Perot, would it be on a case-by-case basis, or do you believe there are more general ideas that could be implemented here with respect to these aspects?
Well, I think any assessment should be done on a case-by-case basis, and there should be a certain amount of flexibility built into the assessment process. But for something like advance directives for MAID, I think that and again, advance directives in general, I think they should be reaffirmed or rewritten periodically, and that should be written into whatever rules or regulations come out with advance requests. I don't think that a clinician could reasonably be expected to act on an advance request that was written 25 years ago and never revisited or reaffirmed. And that affirmation could come as simply as adding a line to an advance directive with a statement saying, I confirm the wishes above of this advance directive. And so that could be done periodically. But I do think an advance directive or advance request for MAID has to be reaffirmed periodically.
Thank you for that, Dr. Perot. And certainly that makes it very, very difficult for those of us trying to create legislation around this to understand those benchmarks and barriers that need to be in place. So I thank you for your comments with respect to that. And through you, Chair, I think I might have about 30 seconds. Professor Rayner, do you have any comments specifically around that?
Yes. I guess what I would say is that it's really in the interest of the patients, the requesters, to reaffirm as often as is appropriate, given their relationship with the provider, to ensure that the consistency of their views are heard, because that makes it more likely that they will get the result that they asked for.
Very good. Understood, sir. And I guess
Sorry, Dr. Ellis, we're out of time. Thank
thank
you
you,
very
Chair.
much. Okay, and next we'll have Mr. Maloney. You have the floor for 5 minutes.
Thanks, Madam Chair, and thank you to all of our witnesses for your comments so far. Very helpful. So, Professor Rayner, I want to start with you. Your 5 points, I'm going to go to your fifth point. You said asking the requester to deal with, I guess, unforeseen scenarios or the third-party objections or obstacles that might arise at the end when you're not in a position or don't have the capacity yourself to respond to them. Do you have, can you flesh that out a bit for me just to get right to the point?
Yeah, so it's entirely possible that that you as an individual might behave, particularly with dementing patients, might behave in a fashion in which you might resist at the time of provision, just might be resisting all kinds of treatments at that point. And that is a very difficult situation for a MAID provider to deal with. That's what they have told us, is that those sorts of situations are extremely stressful. They're trying to figure out what the right thing is to do. If you as an individual it's explained to you that this sort of thing happens from time to time, you can say, well, if I am resisting, I want you to go ahead. And that provides a degree of comfort. I don't think that provides 100% assurance that everything will go as you wish, but a degree of comfort to the MAID provider that they are doing the right thing at the right time in the right circumstance. And there are a number of these kinds of things that go south, I think, regularly as people, as their dementia progresses. Or families intervene in various ways that are problematic, or even the one that has been discussed, I know, here in the committee, the situation of the happy demented patient.
Right.
If you delineate what you want done in those situations, you give clearer instruction to the MAID provider.
Look, I mean, you're never going to get to a situation where you can sort of cover off every scenario. Is that fair? But what you're talking about is trying to anticipate as many of the challenges you can, and that goes to your fourth point, which is discussing the issue with family and close contacts.
That's correct. I think that you've already heard from, I think, some MAID providers who have suggested that nothing will be foolproof and guaranteed. But what we want to do is we want to set up a situation so that it's as likely that you get the outcome that you want with the kinds of constraints that are important to you. If your situation is that you don't want MAID, if you're a happy demented person, then that's what you also need to put forward. And for many people, that might be the way that they want to go.
Back to your premise, which was, it's not as simple as filling out a form. I mean, doctors want to make sure that the instructions are clear and that there's informed consent so that when the time comes, they know that they're acting in accordance with the instructions of the individuals, right? And if I understood you correctly, your point was that if you add this clarity, the number of doctors who are willing to comply with those instructions increases. Or did I misunderstand you?
Yes, well, that's what we anticipate. Of course, we don't really have advance requests for MAID, so all we have is the hypothetical that we presented to these MAID providers. But yes.
And informed consent is the biggest part of this, but informed consent means that the person who is providing instructions to a medical practitioner means they understand as many of the scenarios and risks and problems that can be anticipated at the time. And if I'm in a situation, I'm coming to a doctor and asking or making an advance request, and I understand that I might be in a position where I don't have the capacity physically or mentally to change my mind or convey a different message at the time, isn't that informed consent? Because I'm giving you consent being fully informed of the risks that are in place at the time.
Very briefly, Professor.
Yes, that seems to satisfy what I would consider to be informed consent.
Thank you very much. And next we will have Monsieur Tapiro for 5 minutes.
Thank you very much, Chair. Thank you to the witnesses for their presentations. They've been very interesting. I'm going to start with Professor Reiner. You were talking about confirmation from time to time, and in all cases when you talk about neurocognitive degenerative diseases, we've heard that the absolute condition is to decide what the proper diagnosis is. You agreed that you have to have a definite diagnosis without before you go on to an advance request. And when we talk about a neurodegenerative disease, I mean, that could happen over a number of years, but it's rarely over 20 years. Do you agree?
So I guess I can speak for myself that I generally agree, but really what I'm trying to represent for you is the perspectives of the MAID providers, and we didn't discuss that, so I'm hesitant to comment.
So you're not certain that before accepting an advance request, there must be a definite diagnosis for a neurodegenerative disease?
It's not that I'm not certain, it's that it's outside of the domain of our study, and it wasn't something that we looked at.
Okay.
Okay. With regard to your point 5 and point 4, you say that you have to discuss with the family, and a number of witnesses have said that in addition to the diagnosis, right from the beginning, right from the beginning of preparing an advance request, you must identify a third person who will be the designated person who, when the time comes, based on the wishes of the requester, will ask the medical team to intervene.
Donc, un tiers beaucoup plus que la famille, là.
A third person in addition to the family.
Yes, I think that that's actually an extremely excellent suggestion. And the more people that you confer with, the more people that you lodge your autonomous wishes with, the more likely you are to have them expressed at the right time when provision of MAID should be delivered.
Dans le traitement des maladies.
In treating a degenerative neurocognitive disease, usually it's a process that goes on over time. And so there is a care team that is involved in the care for this person. The will of the person concerned is known to all of them. Should we have a law where we open the possibility, but there should also be a regulatory framework to decide on the application of all different types of advance requests?
Parce qu'ils ont l'expertise.
What I was saying was that the people who are the doctors, colleagues, they have their expertise, their clinical expertise. So rather than putting a detailed text in the law, we could allow this under the law. But in practice, this would be the regulatory authorities that could then establish the guidelines for this.
Yes, I think that that's quite reasonable. I think one thing to remember, as I understand it, ultimately the decision to provide MAID is going to rest with the MAID provider. So the point of all of the recommendations that I put forward here that came out of suggestions from MAID providers is setting up the structure so that they are confident that they're doing the right thing at the right time. And so I don't think we want to add more work and burden on them. I think that the idea of a designated decision maker who acts as a support person for ensuring that the providers know that it's the right time to do what they need to do.
Thank you, Professor.
Is what we should have. Okay.
And next we'll have Mr. McGregor. You have the floor for 5 minutes.
Thank you very much, Madam Co-Chair. Dr. Perreault, I'd like to start with you. So, I mean, we on this concept of relieving people's suffering and the existential dread they have when facing their end of life. We know that a major reasoning behind the amendments in Bill C-7 in the previous Parliament, the waiver of final consent, was to allow people to have a little bit more peace of mind so that if they were diagnosed with an incurable disease that was on a downward decline, they at least could give final consent before worrying about a loss of capacity. But you talked about how allowing for advanced requests would allow that as well for other patients to relieve their suffering and any existential crisis they may have regarding a future loss of capacity. Can you just fill us in a little bit more detail on that, please?
Sure. I think the main difference is that with Audrey's amendment in C7, the person has to have set a date for MAID. Mm-hmm. And many patients don't want to set for a date for MAID yet, but they can't sign that waiver of final consent until they have set a date for MAID. So what patients are asking for is to be able to have an advance request that they could then have in the event that they become incapable before they're willing and ready to set a date for MAID, that's what would relieve their anxiety and suffering. And so, I have many patients who would like MAID, 6 months or a year down the road, but they don't know exactly when, and they feel stuck.
Yeah, and you would say that that's been negatively affecting their life, that having to weigh that the decision that's before them?
Absolutely.
Yeah.
I mean, the 2 patients that I met yesterday, a 72-year-old man with chronic pain and a vascular dementia, he's living quite happily, but he wanted to know that if he had a stroke next week, that he would be able to have MAID. But he doesn't want to set a date for MAID, and he's not really suffering intolerably yet, so he wouldn't meet the criteria. So he's not able to. And an 85-year-old woman with terminal cancer, what she's living with, it kind of boggles my mind. But she also didn't want to set a date, but she knows that if she develops brain metastases, she's quite likely to lose capacity. And so she wanted to be able to set an advance request. And she's somebody I will stay in close contact with because I am concerned about her losing capacity, and I want her to have the choice of MAID, but she's just not ready to set a date for MAID. So it's people like that it would really make a difference for. And I'm providing MAID for a woman in a couple of weeks, and I first met her a year and a half ago. What she really wanted was an advance request, and her past year and a half would have been much more peaceful had she known that in the event of incapacity, she would have been able to receive MAID. And so now that she has set the date and she has the waiver of final consent, she's happy. She's much more at peace.
Professor Reiner, I'd like to turn to you and appreciate the 5 key points that you asked our committee to pay attention to: the list of specific circumstances, regular update of wishes, why each circumstance would constitute suffering, discussing those decisions with the family, and also providing some context when things don't go according to plan. A lot of our witnesses have talked about the present self making decisions for the future self, and I'm just wondering, as a professor of neuroethics, how have you approached that particular argument? We had a lot of people talk about how your present self, I may not fully understand as a 43-year-old what my 75-year-old self would want. And so therefore, how could I properly make the decisions for 75-year-old Mr. McGregor? Can you lend some of your expertise to that conversation?
Yes, I'd be happy to address this. So it's really an issue of who it's about autonomy, and it's about how we project our autonomy. And really, what advance requests do is they project our autonomy into the future, into the person that we will become. And we know that we change all the time. From day to day, you are changed by my words in some way at this moment. So it's not that we are fixed people at any time in our lives. It's really a matter of the question, if somebody is to decide for me when I am in this debilitated condition at some unknown time in the future, who best is in a position to make that decision? And I think that as a scholar of the neurobiology of autonomy, because I've published on it extensively, I would say that clearly it is me. But there is also a penumbra of autonomy that exists in the reality where we're not quite as atomized individuals as we think. And that's where the family and friends and other people come in, and including them in that discussion is very important. But the decision should properly rest with me.
And at this time, I will hand this over to my co-chair, Mr. Garneau, for questions from senators.
Thank you, Senator Martin. And nous allons commencer avec la sénatrice.
We're going to start with Senator Meji, 3 minutes. Thank you very much, Chair. My question is for Ms. Gibson. You said earlier that there must be a clear description of when the process must be started, and that's right. The individuals say when they will start it, and there will be a consultation with the family. But you also said that some of your patients have to be evaluated every 3 months. And would it be the doctor who will do these evaluations to say that this person is eligible? And is it that evaluation will re-examine whether the person wants to maintain their request?
Madame Meji, I think it may have been Dr. Perreault who was talking about the iterative process of checking in with her patients. But I'm happy to touch on this point because I think it's really important, which is to say that one of the reasons why we may want to set up a regime, whether it's legislative or regulatory, whether it's a focus on clinical guidelines, to have regular check-ins with patients who might have made an advanced request, is to confirm that the terms and conditions of that request continue to be current. And as we see especially with longitudinal neurological conditions, there can be changes, life experience changes. And as Dr. Rayner actually pointed out right now, our views may actually change over time. And so being able to have those checkpoints are an opportunity for confirmation and affirmation. But as I learned from Dr. Poirier, who spoke at a recent committee meeting, and also reinforced by Dr. Perreault, there are, depending on where a patient may be in the trajectory of their illness, more frequent check-ins or reassessments and reaffirmations may be both valuable and welcome, especially for a patient who may be concerned that they want to ensure that their conditions are in place, that their advance request will be honored. And so I think we need to be able to find a way to ensure that we have mechanisms in place for that iterative reaffirmation without constraining not either patients or the care providers who are working with them to a set of guidelines that are so strict that it doesn't acknowledge and it doesn't follow the trajectory of a particular patient in the circumstances of their illness, where it's their affirmation of their continued advance request that needs to be confirmed.
Excuse de vous avoir prêté ces propos.
Thank you. Dr. Perrault, do you have enough resources to undertake this 3-month evaluation, or have you already done it in other circumstances, because this has not yet been adopted with regard to advance requests? How do you see the situation?
I think there's been a misunderstanding with my 3-month reevaluation. That comes when I'm actively assessing a patient for medical assistance in dying. That's completely separate from an advance request. So an advance request, I think, should be reaffirmed every 3 to 5 years. Whereas if I'm assessing a patient for MAID who's not ready to set a date for MAID yet, I will check in with them in 3 months' time just to see where they are in their illness process. Usually when patients contact me for MAID, they're closer to end of life and their conditions are more fragile and unstable. So I want to make sure that I catch them if they want MAID at a time that they're still able to proceed with it. So I apologize for that misunderstanding.
Merci, Sénatrice.
Merci.
Thank you very much. We'll now go to Senator Dalphond, 3 minutes. Thank you very much, Chair. I understand that Dr. Reiner hadn't really answered the question from my colleague, Thériault, but I would like to ask a question about when we talk about 20 or 25 years that might go by before the event, and do you think that if in the context of an advance request 20 years from now I have a cardiac event and I might be at risk of dying, and then other experts and have spoken about dementia, and in such cases, should we not have a previous diagnosis before the information process, the reflection process can begin, so that the person can make an advance request spelling out what step of their life they would like to have this take place? Dr. Perrault, have you understood everything that I said? Nice.
Answer to the question, so I asked the same questions that Mr. Thériault to you, so I can repeat in English, but essentially it's to define, you refer sometimes to 15 years, 20 years ahead of the condition, which seems to indicate that I could do it and say if I have a car accident and I remain brain damaged, I could receive MAID, or versus other experts that have said it should be limited to neurocognitive diseases. And therefore, once the diagnostic has been given that you are suffering from Alzheimer and you still have the ability, you can inform yourself, you can talk with the consultants, you can talk with your team, and then start planning, if I want it, at what stage I will define precisely I should receive it.
I do think an advance request should be able to be made for anybody, whether they have a diagnosis of an illness or not, because with some illnesses like cancers with brain metastases or dementia, you can be pretty certain that at some point there is going to be a loss of capacity. But anybody, I mean, any of us could lose capacity tomorrow through a stroke, a heart attack, car accident, or whatever. I personally would like to be able to have an advance request for MAID and I have clearly delineated the criteria that I would want to be met in order for me to have that. And I have that in my advance directive for if and when it does become legal. But I think that's really important. So yes, I don't think it should only be for neurodegenerative conditions.
And then if I understand properly, what you're saying is that since that might be over a long span, then it should be reaffirmed or reassessed periodically every 3 to 5 years.
Absolutely, absolutely. I think one should rewrite or reaffirm an advance request, like the same way I think we should do that with wills and powers of attorney in general to make sure that our wishes are consistent. So to Mr. McGregor's point, his 45-year-old self may not know what his 75-year-old self is, but I would hope if he writes an advance directive at 45, he would review it at 50, 55, 60, 65, 70, 75. So his 70-year-old self might know better what his 75-year-old self would want. The other
Merci,
thing to point
Sénateur
out is that
Dalphond.
Thank you very much.
Thank you very much, Chair. Two questions. The first question to Dr. Reimer and Dr. Perot, and then the second question to Professor Gibson. There's a difference between legislative dictum and standards of practice and regulation of practice. So how would you look at what we're talking about today? Would you look at its legislation telling physicians and patients how they should interact with each other? Or should there be a standard of practice that physicians rely on and regulators rely on to oversee the practice of MAID, particularly around this area as well? And if that is in agreement, who should set that standard of practice and how should it be regulated?
Well, I'll just speak first, but I think that it makes sense for it to be a standard of practice, and it could fall under the regulation of provincial colleges of physicians or something like that. I think that would be sufficient. The point of all of this is really to try to just make sure that everything goes as smoothly as possible, rather than to tie it up in some regulatory regime that ensures that tick boxes are checked.
Yep. And I agree 100%. I think it should be a standard of practice, not legislated. I think it doesn't make sense to put in the legislation all the details that should be met. I mean, I think there are some details that are in the legislation currently that I wish were standard of practice. It would give more flexibility. But I think that the standards of practice can be created, and there will be advance directives or advance requests that will be written today. If they're written today, they will be refined over time. We will get better at it as we have experience. As a clinician, I include things in my MAID assessments today that I did not include 5.5, 6 years ago because I have learned over time. There are things that I include in the waivers of final consent agreements that I write with patients now that I did not include when I first started out because I've learned through experience, my own in particular, but also from colleagues. And so I think a template for an advance request would evolve and improve over time.
For Professor Gibson, you mentioned that you felt that multiple actors have a role to play. I wonder if you would mind expanding on that statement for us?
Thank you for the question, and I think it really builds on your previous one. If we think about, there's the legislation, I think the clinical guidelines developed by those who are best equipped as clinicians to be able to inform what practice may look like is going to be important. I also think, though, that there are other actors that we want to be thinking about. One key actor here who I know has been identified, but both at this committee, but also it surfaces fairly frequently. Substitute decision makers play such an essential role in this process. Dr. Reiner's process that he's outlined, I think, is very well suited to supporting a substitute decision maker to be well equipped, but with understanding of why a patient may actually be seeking an advance request and be able to be part of that deliberative process. That is an actor. I think there are other actors that have essential roles to play in ensuring the system around this works well. A strength of the original Bill C-14, our original legislation was that there was a monitoring system in place, that we were able to track and understand what was going on in the practice and to be able to guide continuing policy evolution. But that is a high level, often using quantitative data, sort of reporting statistics, very helpful at a population level, but we need to go further down. And this is where some of the other opportunities we have to really strengthen this system as a whole is to continue to foster the types of research that Dr. Reiner has been pursuing, to really continue to foster the learning and the training of health professionals.
Thank you, Doctor.
Dr. Perot's sharing as well. It's everyone's in.
Thank you. When I go to Senator Martin for 3 minutes.
I don't have enough time to ask all my questions, actually. And as we come to a close on advanced directives, I feel like we have so much more to explore. And really, this is a very important and big topic. So maybe I can just focus in on just the restrictions that are needed to ensure that like we really are doing the right thing. So for instance, under what strict conditions should the arrangements be made for advanced directives? And under what conditions should the procedure be abandoned? We talk about family involvement along the way, but there's also, I know there are issues sometimes with family involvement, both positive and negative. And at what point should an advanced directive be abandoned or a procedure be abandoned? So if we're expanding advanced directive beyond the waiver of final consent currently allowed, what protections are necessary? So I'm really focusing on the protections that are needed for a very reliable system. So maybe I'll begin with Dr. Perreault and then Professor Rayner or Reiner. I've heard both. So it's Dr. Perreault.
I would say that the more clearly and filled with detail an advance request can be, the more information will be provided to a MAID provider. I think it's important to recognize that MAID providers wouldn't meet a patient until an advance request is acted upon and the MAID provider is contacted to provide MAID for somebody. So the MAID provider never meets the person when they were capable. They have to be able to understand what that person would have wanted based on their advance request. And that's the main thing for.
Is the form consistent? Is there a standard that you're collecting these details consistently across the board? Would you explain a little bit about the form that is used or the process?
I think an advance request is written usually in a lawyer's office with a power of attorney document, I would think. The Center for Bioethics had an excellent template a couple of years ago. I wish they had not stopped producing it. Dying with Dignity Canada has an excellent template, and there are a number out there which I have used, and I pull from a number of them to create the advanced requests that I have written and that ones that I recommend to my patients use. But there is no master template that is used universally, and we don't have a master template certainly for advanced requests for MAID because it's not possible yet. There's no master template for the waiver of final consent. I drafted my own when it became legal, and I have revised it over time and improving it, adding things to it so that it's as clear as possible to me, because when I meet the patient, I want to understand what they need and want, what their suffering is, what their criteria would be. And so I ask them to write things down, and I help them to drafted in a way that makes sense to me. Usually there are family members or friends present when that's done so that they understand what's going on as well. But I have to say, I also have a lot of patients who do not have family members close by, who don't have family members at all, or don't have family members that they can trust to do this. So I am concerned with the idea of having to include family. I mean, I have a couple of patients right now whose families are being very obstructionist and are not allowing them to proceed with MAID, and I can't do anything without their cooperation. It makes it very, very difficult, and so the patients are not getting access. So I think that may be even more pronounced if there's an advance request that requires a family member to be involved. I hope that answers your question.
Thank you, Senator Martin. I'll now turn it back to you.
Okay, and if I may again thank our witnesses for your testimonies this evening. It's very helpful to all of us as we continue in our study. So thank you so much. And we'll suspend for a few minutes to get ready for our second panel. We will resume, colleagues. Just a few comments for the benefit of our new witnesses. Before speaking, please wait until you are recognized by name by one of the co-chairs. Reminder that all comments should be addressed through the joint chairs. When speaking, please speak slowly and clearly. And interpretation in this video conference will work like in an in-person committee meeting. You have the choice at the bottom of your screen of either floor, English, or French. And when you are not speaking, please keep your microphone on mute. Thank you very much. So welcome to all of our panelists for this discussion on mature minors, a very important topic for us, and we really appreciate the time that you're giving to our committee. So we have three panelists. The first, Dr. Catherine Morrison, clinical and organizational ethicist. We also have Dr. Gordon Gubitz, professor, Division of Neurology, Department of Medicine, Faculty of Graduate Studies at Dalhousie University, and Kimberly Widger, associate professor, all by video conference. So I will first begin with Dr. Catherine Morrison. You have the floor for 5 minutes.
Thank you. Good evening. Thank you to the committee co-chairs and members for the invitation. I am deeply honored by the opportunity to speak with the committee on this very important topic. I am a philosopher, having completed my PhD in applied philosophy at the University of Waterloo last year. My dissertation research considers moral arguments regarding mature minor eligibility for medical assistance in dying, or MAID. The scope of this work is focused on cases where minors have a reasonably foreseeable natural death, that is track 1. I also bring the perspective of a practicing healthcare ethicist at a large hospital network in Ontario, where our service supports patients, families, and healthcare teams who encounter challenging situations regarding informed consent, capacity, and quality end-of-life care. As part of my clinical ethics role, I support one of 4 specialized pediatric hospitals in Ontario. Our service also supports the institution's MAID team, where I had the privilege of doing MAID coordination during my ethics fellowship. The views I bring to the committee are my own and do not represent the views of the organization I work for. MAID for mature minors is an emotionally challenging topic, presenting unique challenges when it comes to core values outlined in the Carter decision. Society has an interest in protecting vulnerable persons, and children are often perceived as vulnerable, entailing stronger duties to child well-being than that of adults. Yet at the same time, there are societal duties to autonomy, especially respecting capable persons to make decisions about their own medical care and avoiding forcing persons to endure intolerable suffering against their will. Children have a legal right to decision-making autonomy corresponding to their level of maturity. This tension between welfare and autonomy puts significant scrutiny on a mature minor's capacity to make such a serious decision. I wish to present 3 considerations to the committee, which I believe provide compelling reasons for mature minors to be eligible for MAID under Track 1. The first is the concern that excluding minors from accessing MAID is discriminatory. The 2016 report of the Special Joint Committee on Physician-Assisted Dying articulates that mature minors can suffer as much as adults. It is also conceivable that minors with a grievous and irremediable medical condition who are prohibited from MAID can experience the same harms as adults. This differential treatment is challenging to justify in the same way we would justify age distinctions in other contexts, including decisions to marry, drive, drink alcohol, smoke tobacco, or use cannabis. After all, in the context of treatment decisions, decision-making authority is usually based in presumptions of capacity rather than a firm age distinction. Secondly, child well-being is not always synonymous with prolonging life. In end-of-life decisions, well-being can be informed by dignity, quality of life, and should take into account the harms of forcing mature minors to endure intolerable suffering against their will. Lastly, it's important to acknowledge that mature minors already make incredibly high-stakes medical decisions, including the decision to refuse life-sustaining treatment. I argue that refusing life-sustaining treatment, that is, a decision to die when one could otherwise live, is a far more serious type of decision than the decision for MAID under Track 1, that is, choosing to control how one dies when death is unavoidable. In this sense, mature minors are already treated as meeting the threshold of capacity and maturity required to understand the implications of MAID. It is challenging to reconcile these considerations under Track 1 with the recent expansion of the law to include persons without a reasonably foreseeable natural death, that is Track 2, and anticipated inclusion of mental illness as sole underlying condition. While at face value, Track 2 and mental illness as sole underlying condition requests carry a similar weight to the decision to refuse life-sustaining treatment, there is considerable uncertainty regarding the particular vulnerabilities of these patient populations. I would be concerned at the prospect of extending eligibilities to these groups at this time. I will close by emphasizing that the uncertainties raised by Track 2 and mental illness as sole underlying condition should not undermine the case for mature minor access to MAID under Track 1. Again, I thank the committee for their attention and consideration.
Thank you very much, Dr. Morrison. Next, we'll have Dr. Gordon Gubitz for 5 minutes. Dr. Gubitz? Would you unmute?
Rookie mistake.
Oh,
yes,
perfect.
I am. I'm terribly sorry.
That's okay. Thank you.
I'd like to thank the committee for having me here this evening to provide some insights and opinions. Yes, a couple of things. First off, an apology. I thought I was going to be speaking about advanced directives, but I'm happy to provide comments and thoughts about any aspect of MAID and MAID care. I work as a neurologist in my day-to-day work and work with people who've had strokes, many of whom experience intolerable suffering after and cannot access MAID because of a lack of capacity. I've been a MAID assessor and provider in Nova Scotia since the law began 2016, and I am the clinical lead for medical assistance in dying in Nova Scotia with respect to administration and trying to promote good policy, etc. Finally, I'm co-chairing and chairing a national committee that's looking at developing educational standards for MAID across country, which is funded by Health Canada. And so very grateful for their involvement in this process. When medical assistance in dying for minors or mature minors was mentioned, I was taken immediately to a case that I actually saw and worked with a young woman who, when she began her medical journey, was 19, so just above being a mature minor, and suffered from an intolerable pain problem. And she lived with that pain problem for 5 years. She saw endless numbers of medical specialists, surgical specialists, and underwent numerous different treatments for her problem. When I was asked to see her, it was because Track 2 legislation had just been introduced, and I was asked to do an assessment to determine whether she was eligible for death, for a medically assisted death, even though her natural death was not reasonably foreseeable. And on the basis of a review of her entire medical history, the nature of the problem, which was neurological in nature and my understanding of that, and in discussion with consulting experts across the country, came to the understanding that her natural death was not reasonably foreseeable, but there was no option for further treatment for her. And so just shy of her 23rd birthday, she had a medically assisted death in her home, surrounded by her family, and I was there to provide the medication that brought that about. In many ways, the experience of that death was an experience for the entire family. They had gone through this journey with her from when she was underage and beginning to experience the difficulty with this problem all the way through helping her understand and move forward with the treatment decisions, et cetera, et cetera. In getting to know her, it became quite obvious that she had become an expert in her own problem. She had done the research, she had listened to the doctors, she had listened to the therapist, et cetera, et cetera. She weighed her options, and she finally made decisions that she would not want to go through some experimental therapies, which were not likely to help her going forward. She engaged in very frank and open conversations with her parents, initially not necessarily on side, and some family strife as a result of that, but eventually coming around and being able to support her. At the end of the day, she is the closest I have experienced to a mature minor in terms of an ability to go through this process and see it through to the other end. Her death was peaceful. She was surrounded by her family and her friends who lingered, and we stayed around after. I can't remember how many pots of tea we drank, talking about her journey and telling stories. And I'm still in contact with her family to this day periodically. So unfortunately, beyond, I don't have the academic background that Dr. Morrison brings to this process, but I think the clinical aspects of this are very similar to what goes on with adults. It's all about communication. It's all about ensuring capacity. It's all about understanding your options and being able to act upon them. And age doesn't necessarily define what that understanding ought to look like or could look like. I know plenty of people who are in their 40s who are not capable of making decisions and they're not unwell. So I think I'll just yield at that point because I am finished.
Thank you very much. And next we will have Professor Kimberly Widger. You have the floor for 5 minutes.
Thank you very much, and thank you for the invitation to speak today. I am an associate professor in the Lawrence S. Bloomberg Faculty of Nursing at the University of Toronto, and I hold a Tier 2 Canada Research Chair in Pediatric Palliative Care. Prior to shifting my focus to research, I worked for 12 years as a staff nurse, mostly providing care to children with cancer, but also to those with other types of life-threatening illnesses. The overarching goal of my program of research is to examine and enhance the provision of palliative care for children living with a life-threatening illness and their families so that every child who might benefit receives optimal care. Unfortunately, my research continues to show that many children do not have access to specialized pediatric palliative care, and there are some concerning inequities in who accesses this care. Much of this research was highlighted in the final report of the expert panel on MAID for mature minors through the Council of Canadian Academies, as I was a member of the working group. So my comments will focus on the implications of my research for the care provided to mature minors and their potential eligibility for MAID. Palliative care is seen as a fundamental human right. It focuses on minimizing suffering and maximizing quality of life. It is meant to be provided from the time a child is diagnosed with a life-threatening condition through to the end of their life. Palliative care can be delivered in many different ways, but my research has primarily focused on the care delivered by specialized pediatric palliative care teams, namely interprofessional teams of health professionals, typically doctors, nurses, social workers, child life specialists, spiritual care providers, and others, who have expertise in both the care of children and in palliative care. One of my first studies was to examine the teams that provided this specialized care and the children who received it. In 2002, there were only 7 teams like this in Canada, and they provided care to only about 1 in every 20 children who might benefit. We repeated the study in 2012 and found there were 13 teams providing care to 1 in 5 children who might benefit. As of 2022, there are now 17 teams, but I don't yet actually have the statistics on how many children have been receiving this care across the country in the last year. However, based on a couple of relatively recent studies we've done just focused in Ontario, about 1 in 3 children who die from a life-threatening condition received care from one of these teams. So clearly improvements over time, but the progress has been very slow over the last 20 years. In Ontario, we've looked more closely at children who died from cancer and found that those living in the lowest income areas and those living furthest away from a tertiary children's hospital were least likely to receive specialist palliative care. Given the Canadian geography, it may not be surprising that those living further away were less likely to access care. Couldn't it just be provided by adult palliative care providers or general pediatricians? Absolutely. Many of the specialist teams work with these other providers to be able to provide care closer to home, acting as consultants, so the child still gets the benefits of the specialist team. However, we were able to compare the children who received at least some of their care through the specialized teams with those who received palliative care but without involvement of a specialist team, and those who had no indication that they had received any type of palliative care. We found that those with the specialist care were dramatically less likely to have frequent visits to the hospital, to the intensive care unit, and to the emergency department in the last 30 days of their life, and they were much less likely to die in the hospital than those who got no palliative care. Unfortunately, the middle group, the ones who got some kind of palliative care outside of a specialist team, were no different in terms of hospital visits or dying in the hospital than those who got no palliative care. Specialist teams make a difference in the support provided to children and families. As I said at the outset, these teams are experts in providing pain and symptom management, addressing psychosocial and existential concerns, supporting families, maximizing quality of life while minimizing suffering. Yet not all Canadian children are able to access these services. I cannot see how we could allow a mature minor to choose MAID unless all support options are fully explored by a specialized team of health professionals who do this work every day. My greatest fear would be that a 16 or 17-year-old who did not have access to this type of care would be left feeling that MAID is their only option. Thank you.
Thank you very much, and thank you to all of our witnesses for your testimony today. We're going to begin our first round of questions, and we'll start with Madame Vien for 5 minutes.
Merci beaucoup. Thank you very much, Chair. Thank you to the witnesses for sharing their ideas and their knowledge. And I think the angle we want to study with regard to this topic, this is the most moving aspect of concerning mature children. I think I would like to ask you what you think about this issue of the capacity for young people to take this kind of decision, an informed decision. And the second question, Ms. Widger, because there are problems of access across the world, and I'm not particularly for or against, but do we currently have enough information on this situation? And then for you, what are the criteria that have to be included in this legislative framework if we want to go towards allowing MAID for mature minors? So what are the protection measures, safeguards we have to have as well? And so I leave it up to you. You're a specialist, Ms. Widger.
La question est pour Madame Morrison.
The question was for Ms. Morrison. Sorry.
At answering some of the questions. So, so first, I'll start with the question of capacity. So, we know that capacity is often formulated as being time and treatment specific. And so a patient could be found capable of making one kind of decision while incapable of making another kind of decision. And so in the context of some of my research and some of my practice, we have seen mature minors in situations where they are able to make both decisions that entail quite a bit of complexity as far as understanding and appreciation. And there are many factors at play there, whether it comes to experience of illness, experience of suffering, child development, and how their beliefs, values, and cultural norms might apply to the decisions where there are elements of subjective value that are inherent to some of these questions. But we also see that there's different weights usually assigned to decisions. And so the more grave a decision, usually we see a need for a higher threshold. And so what some of my work argues is that we actually see situations where mature minors make incredibly weighty decisions that have grave consequences, especially when it comes to a decision to choose to die, where there's the option of having a long and lengthy future in some cases. And so in those situations where we regard minors as being capable, in situations where a mature minor is at the end of their life, they are not facing a lengthy future, and they're thinking through all their options on how they wish to die. oftentimes we see those decisions as, I argue, as comparatively less weighty. When it comes to safeguards, just a quick note that I would just want to mention that there are many safeguards outlined quite clearly in the Council of Canadian Academies report.
Madame Vien.
Ms. Vien? Well, Ms. Widger, you wanted to answer, or do you have anything to add to that?
Sorry, I had heard my name in the first round as well. But anyways, just to say, in terms of the safeguards, I mean, my safeguard is obvious, maybe, that pediatric palliative care specialists need to be involved in assessing these children and making sure that they truly have explored all options that are available. And, you know, it's sort of, you don't know what you don't know in some cases, that someone might feel they are doing a fabulous job of doing that exploration, but it really takes a team effort of specialists in the area. And so for me, that would be a minimum to have available. COVID has made it better in some ways, that some of this care can be done more so, you know, over long distance.
Just in a few seconds, would you say that because we're dealing with young people, that the medical teams could have people that otherwise would provide made say, well, with young people, no, I don't want to do it, and what is the attitude of health professionals?
So very briefly, Professor Widget.
I couldn't catch the end of that, but.
Okay, I think we are over time, so apologies. We'll move on. We'll go next to Monsieur Arsenault for 5 minutes.
Merci, Madame. Thank you very much, Chair. My first question is for Dr. Gubitz. Thank you, all of you, for being here. A very delicate issue that we have to deal with, mature minors, and I very much appreciate that you've said that you thought you were going to be speaking about advance requests, but you've called on your own experience, and you believe that you had something contributed. And you talked about the young girl who was 19 years old, who had suffered over 5 years before reaching 19 years old, when she could ask for MAID. And with her, it wasn't an issue of age, it was the issue of capacity, of understanding. Could you explain a little bit more the situation, taking into account the request from a mature minor?
On vous entend pas, Dr. Gubitz.
We can't hear you, Doctor.
I'm so used to being unmuted. Thank you for the question. I think in this particular circumstance, I'll link back to something that Dr. Morrison mentioned, and it's the idea that capacity is a fluid thing. We can recognize that children might have capacity to make a decision about what they want to wear to go to school, or what they want to do this or how they want to do that, based on the information that's available to them. Obviously, in Dr. Morrison's experience and her research has demonstrated that children certainly do have capacity to make healthcare decisions, medical decisions, within the context of their understanding. So I think it really does come down to ensuring that enough has been done to allow the child to explore the issues as best they can, to speak about it in a language that is common to them, that makes sense to them, and to be able to reflectively respond to questions about their experience and get a sense of, in the same as we do in the adult world, do you understand what happened to you? Do you understand where you're at now? Do you understand what the future is likely to hold? What do you think about that? And do you understand what your options are? And we might have to do this in slightly different ways.
Yes, but sorry for interrupting, but this brings me to my next question. Is there a difference between a mature minor who enters into your definition of intellectual capacity and reasoning? Is there a difference for you between that kind of a case and an adult? Is there any difference in the analysis of their capacity, or are there any additional safeguards that have to be taken into account?
So I think it will be very situationally specific, right? It has to do with the child's development, their overall understanding. I'm not a pediatrician. I'm not a pediatric neurologist. And so I think, as Ms. Widger has said, making sure that we've got the right people engaged with the children who are in the process of understanding their mortality, et cetera. It's similar to what we do in Track 2 for adults right now, where we need to have someone do an assessment who has expertise in the condition if the people who are doing the assessments don't have expertise in that condition. I really need, as an assessor, to understand that all that can be done has been done to allow us to understand that the patient in front of us knows what's going on, right? It will probably be much more complex, but I agree with Ms. Widger that there will need to be specific, very specific safeguards for these children who hopefully are not going to be coming at the, it's by the hundreds, right? Because that would be terrible. But there will be very specific children who will meet the criteria and will be found by people doing the assessments to have capacity to make decisions about their health.
1 minute. Mr. Arsenault?
Mr. Arsenault?
Désolé, Madame.
Sorry, Chair. Ms. Morrison, Dr. Morrison, could you add to what Dr. Gerbitz said with regard to any supplementary safeguards that should be considered for minors? And what would they be?
Very briefly.
Thank you very much for that question. And I will just endorse the testimony of the other two expert witnesses around, the need for clinicians with expertise with this population. I also do want to emphasize when we think about decision making, the alternatives to a decision are an essential part of informed consent, and that's also true of mature minors. So, when we think about a decision, the alternatives need to be clearly laid out and need to be as accessible as possible.
Thank you very much. Next, we will have Monsieur Thériault. You have the floor for 5 minutes.
Thank you very much. Dr. Gerbitz and Dr. Morrison, does parental consent have to be a legal requirement, or is it rather a consultation with the parents that should be included when we refer to someone who's a teen or a mature minor?
L'un des deux, là.
Either one. Dr. Morrison or Dr. Gerbitz.
Followed by Dr. Gerbitz. Dr. Morrison.
Okay, apologies. Felt like we were in Zoom freeze. So I think that's a really important question to ask because we know in the Benelux countries where mature minors are able to access medical assistance in dying, parental consent, at least in some cases, is a requirement. I think that it's a challenge because on the one hand, parental presence in medical decision-making is often seen as autonomy enhancing in some respects. However, we do encounter those cases where there are deep concerns about, how the role of the parents might impact autonomous decision-making for minors. As we see in the adult context when it comes to MAID practice, the role of family members can be, it's a dual challenge. It's autonomy supporting, but can also be autonomy limiting. I think that a big challenge when it comes to mature minors is the compatibility with our framework around treatment decisions, because oftentimes where a patient is capable, including a minor, minor, there is usually no role for family members to be making decisions on a patient's behalf. So I think it would be a challenge to require parental consent. Consultation, I think, is a bigger conversation.
And Dr. Gubitz?
Yeah, I would agree. Once again, I'm not an expert in the definitions of what a mature minor would be legally. So I think the committee may wish to sort of have a look at that and get an opinion about what are we actually speaking about when you speak about a mature minor as opposed to an emancipated minor, et cetera, et cetera. I do agree that family is really, really important in the over 18 world. When we think about medical assistance in dying, we don't necessarily talk about family. We talk about those who are supporting them, because families come in all sorts of shapes and sizes, and some are very toxic and some are very supportive. So, fortunately,
sorry. You said that you agree, but you agree with Dr. Morrison that legally requiring consultation but not consent from the parents.
I think an assent approach would be more useful. It's really about the conversation and about the nature of the relationship with the family, and recognizing that if this child is very ill and is going to die, that the family is going to carry on afterwards, and you would rather have a family that carries on together as a unified whole rather than a family that is fractured into pieces and never speaks to each other again. So, and I think that can be the role of the team that's involved in doing the assessments and providing that level of support.
I have another question, if I still have some time. In your practice, Dr. Gubitz, I imagine that these kinds of decisions, which are rare, are taken jointly in most cases. Should we limit the accessibility to MAID for mature minors?
Fortunately, sir, I'm not a pediatrician, and I can't really comment on that. It is not my practice. So I deal with people who are able to give their own consent. So I would defer to the expertise of the other witnesses around that who've studied.
Alors, Dr. Morrison,
Dr. Morrison.
Briefly.
I apologize. Could the question be repeated? I just also want to stay in my lane, as I'm not a pediatrician either.
Okay, we are running out of time.
Merci.
Thank you. Should we limit MAID to for a mature minor to just one voice or one?
Dont la mort est raisonnable.
For a reasonably foreseeable death.
So briefly, Dr. Morrison.
Apologies, I'm just hearing the translation and having some trouble interpreting the question. I interpret it as allowing for mature minors to access MAID under track 1.
Okay, thank you, Dr. Morrison. I think, unfortunately, with time, we have to move on, so apologies on that. So I'm going to give the floor to Mr. McGregor for 5 minutes.
Thank you very much, Madam Co-Chair, and thank you to our witnesses for what is a very difficult subject. And I appreciate this as a parent first and foremost, and I think the difficulty is that parents are driven by a desire to protect their children, and when at the same time juxtaposing that with a child who might be undergoing obvious suffering. I guess we are lucky in a way in that each of our provinces already have provincial laws in place, healthcare laws in place. Like my home province of British Columbia, they state in general parental consent for healthcare in BC is sought for children 12 years of age and younger. However, there is no legal age of consent. Basically, mature minor consent is the consent of a child or youth gives to receive health care after the child has been assessed by a health care provider as having the necessary understanding to give that consent. And I guess to you, Dr. Morrison, I know that it's not so much tied to an age, it's tied to sort of the general understanding that the child has. Can you, first of all, give us an example of, when a child is coming in with their parents, how you guide that relationship? Like, do you have to have a time where you're actually like sitting down with the child alone? And can you give us an example of like the types of questions that are asked to try and assess whether that child has the understanding of what's coming their way?
Thank you for the question. Unfortunately, I am not a physician myself, and so I do not, I'm not a healthcare, frontline healthcare provider, so I do not do capacity assessment. So I would defer to the other witnesses on this question.
Dr. Gubitz, do you have anything to add, like on that? If you have anything that can help guide us on that.
I can only reflect on what happens in the situation with adults. We often will do interviews with the person seeking a MAID assessment and with their supporters, their loved ones, whomever. We will often find a way to have a conversation separately with the person, just to ensure that they're not being coerced one way or the other into making a decision. More often than not, when people are thinking about this, they've been thinking about it for a long time. And oftentimes when they come with somebody who has been there with them on that journey. They understand the illness. They understand that this is going to be a difficult conversation. They're there to be supportive. Rarely we have circumstances where people are not supportive, so clearly they picked the wrong person. I could see the same thing happening with parents, with children, except, ramp that up tenfold in terms of the concern and as you've mentioned, the idea about thinking of this as a parent. So once again, it gets down to that, the degree of comprehension, the degree of support of a team around this group of people to work through this process together, recognizing that the decision is not going to be made like that. The decision is going to be a process rather than just this immediate, and we're done.
Dr. Morrison, maybe I'll try and word it in a way that respects your expertise in clinical ethics. I guess to what extent should the quality of end of life care be considered as a factor when we're assessing this? I just take Dr. Widger's comments about we want to make sure that specialized palliative care is available so that every child who may potentially find themselves in this situation has at least had the opportunity to make that informed choice, to have experienced the full range of care options. Does your practice or your expertise in this field inform anything that you can say on that?
Yes, because oftentimes clinical ethicists navigate very challenging situations regarding informed consent to treatment. And so I think that Professor Widger's really important comments around the accessibility of palliative care is important to inform mature minors around all of their options when it comes to end-of-life care. In some ways, it's very challenging to say that an informed decision has been made without full knowledge and accessibility of all available options.
Thank you for that. That's it for me, Madam Co-Chair.
Thank you very much. And I will now turn this over to my co-chair for questions from senators.
Thank you, Senator Martin. Nous allons commencer.
We'll begin as usual with Senator Meji, 3 minutes. Thank you very much, Chair. My question is for Ms. Widger. You are a nurse working with children and with terminal illnesses. Are you aware of, or if not, what do you think about the importance of ensuring participation of young people in decisions where there's such a major issue, a challenge, whether it be the children are ill and or even children who are in relatively good health. Ms. Widger?
So yes, my experience as a nurse, I have not been at the bedside for quite a while, but certainly have been involved with children, young adults, or older teenagers, I guess, who are making decisions that impact their life, very much so. And there's a range. There's no two 16-year-olds who are the same. I've cared for, one at the same time, cared for two 16-year-old girls who one made all the decisions with her father with her, but he absolutely let her make all the decisions. And I think she could have very much made this kind of decision. And another 16-year-old who didn't want to be a part of any of the meetings, really didn't want to talk at all and make any decisions. And so they're completely different children. They bring different experiences to the situation. Also a big difference in someone who was diagnosed when they were 3 with something and are now 17 and have lived with and been involved in decision-making all the way through versus someone who was diagnosed 3 months ago. So it's hard to, I can remember many children who could have made this decision in my assessment, and many of the same age who could not have made this kind of a decision.
And you think that the best way to discuss this is to look at what's happening in other jurisdictions who have experience in this area? I mean, there aren't that many. Are you familiar with what happens in other jurisdictions?
So yeah, there are not very many other jurisdictions, and those who do have it in place, the numbers are very, very small. Now, to be honest, I haven't looked at the numbers since we did the report on mature minors as part of the working group. So I don't know if their numbers have gotten bigger over the last few years, but the numbers were small. And there was a study that was done asking Canadian pediatricians about how many times in their career they'd been asked about, wasn't even called medical assistance in dying at the time, but, and they talked over their career like there was a total of maybe 20 mature minors who had asked about MAID explicitly over the course of many, many pediatricians' entire careers again. So I hope the number would be very small, but I think the number of adults who've taken advantage of MAID is much higher than what we thought it might be when Canada started down this path. So who can say?
Thank you. We'll now go to Senator Kutcher for 3 minutes.
Thank you, Chair. I have 3 questions. They're all for Dr. Gubitz in a slightly different area. I think you can help us in your role as chair of the MAID curriculum development process. So I'll just say the 3 questions and then ask you to respond. The first question is, will this curriculum that the group is working on be of a similar standard to other curricula currently used in the training of physicians, family physicians, or specialists from the Royal College? The second one, will this curriculum provide an opportunity to standardize MAID assessment and delivery across Canada, so improve that standardization? And thirdly, will this curriculum assist professional and regulatory bodies to set standards of care for MAID, similar to what we currently have in all other aspects of medicine in Canada?
So the first question had to do with the quality of the educational curriculum that we're developing. The curriculum will be accredited by all of the Royal Colleges, so the Royal College of Physicians, the Royal College, or the Canadian College of Family Physicians, and the Canadian Nursing Association, as they're actually partnering with us on the development of this, and they have eyes on the project through all of its stages of development, but it will go through an accreditation process. With respect to the second question about creating an educational standard across the country that's comparable to what one might see elsewhere. The reason that this curriculum was developed was because there is no training formally for MAID in any form across the country. It arrived as a legislative change, and then it was see one, do one, teach one, and eventually through the Senate request of CAMAP to develop the program, we now are developing a basic training program for clinicians who are interested in developing their skills around MAID assessment, MAID provision, through a series of more basic assessments, through more complex assessments, capacity and vulnerability, et cetera. I think that with respect to the third question, all of the provinces and territories presently have standards that we follow. So in Nova Scotia, our College of Physicians and Surgeons has a standard that I must adhere to. We work with our college to ensure that they will have access to this information, and we would work hand in hand with them to improve the legislative standard as it would be required. So I think there's only upsides to having a national standardized education process for MAID. To anticipate the question that might come, we don't have a standard at the present time for pediatrics or for mature minors, only because it's not part of the law yet. But I imagine that as time goes by, that might be something that happens if this becomes part of the federal legislation.
Thank you, Senator Kutcher. Senator Dalphond.
Senator Dalphond. Thank you very much, Chair.
Question was the one that Mr. Thériault tried to have an answer, so we'll repeat it. So we'll answer his questions and mine. I understand that from the testimony of Dr. Morrison that she thinks that if we go, two things that are important. We should look at maturity instead of age, because this is not necessarily equivalent. And the second thing is that if its access is provided to MAID for mature minors, it should be limited only to track 1. So would you, Dr. Gobids and Mrs. Widger, agree with that?
I'll go first. Thank you for the question. I totally agree. I think when MAID came about back in 2016, only track 1 existed. And we learned over a period of time what that looked like. And through that and through gauging the Canadian response to this, we were eventually able to lead to track 2 and to Audrey's amendment and all of those sorts of things. So the low-hanging fruit first, and then working and getting a sense of what makes sense. What does our experience teach us? I think to go immediately to track 1 and track 2 for mature minors might be more than the Canadian public is willing to handle. I think we need to approach this thoughtfully, cautiously, and in a stepped approach. That's my opinion.
Yes, and I would agree with the same.
Merci, Senator Dalphond.
Thank you, Senator Dalphond.
For 3 minutes.
Thank you. My question is for Professor Widger. As you're aware, the CCA working group concluded that there are many gaps in knowledge that make it, quote, difficult to arrive at definitive answers, end of quote. And only 3 countries, as you mentioned, allow MAID for minors, and so few cases, so there's very limited data. So given this lack of data, do you think it's prudent to move ahead with MAID for mature minors in Canada, or would Canadians be better served for this committee to recommend that government undertake further expert research on the issue?
That's a very big question. I think, the youth voice is still missing from the work that's been done to date. I know Dr. Franco Carnevale had testified before this committee in June, I believe, and that's some work that he is doing, and I think it really is important work. And I think it's important to not just rush into things, as you say. A more stepped approach may be better and serve us better in the long run. On the other hand, if I was 17 years old and 250 days, like forcing me to wait just seems crazy if I'm capable of being able to make a decision. So I don't have a good answer to that question.
It was a big question, so thank you for responding as you did. And beyond specialized pediatric palliative care, which I think is so important, are there other services and supports that are needed for certain groups such as Indigenous, racialized, or disabled youth?
Yeah, and I think those are the groups that we really still have not heard from. the Indigenous population in particular, in terms of how this fits with their views and ways of being in the world. We have not looked at that really at all. So that, yes, is absolutely a critical component. And I think, yes, mature minors with disabilities, to me, is a different population than those with a terminal illness, the track 1 group whose death is foreseeable in the very near future. Most of those with disabilities, that would not be something so that's in the near future. So maybe that's, a different track kind of thing. So yeah, more research needed in those areas for sure.
Thank you, Senator Martin. With that, I'll return it to you.
Okay, and simply just to say thank you to all of the witnesses. It's a difficult topic, and your expertise, your recommendations, your guidance is very important to us. So thank you very much on behalf of our committee. And with that, colleagues, we conclude. Thank you.
Thank you.